Recording starting.
Start off. ಅದು ವಿಡಿಯೋ ಒಂದು ವಿಕೇಶ್ ಇನ್ ಬಿಟ್ವೀನ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಆಫ್ ಮಾಡಿ ಈಗ ನಂದು ವಿಡಿಯೋ ಐ ಮೀನ್ ಐ ಹ್ಯಾವ್ ಟು ಪ್ರೆಸೆಂಟ್ ಸಮಥಿಂಗ್ ಟು ದಮ್ ಅದು ಹೆಂಗ್ ಮಾಡೋದು
ವಿಡಿಯೋ ಅನ್ಮ್ಯೂಟ್ ತೆಗೆದ್ರು
ಇದು ಅನ್ಮ್ಯೂಟ್ ತೆಗೆದು ಐ ಕ್ಯಾನ್ ಡೈರೆಕ್ಟ್ಲಿ ಓಕೆ
ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ
I'll start now. Good evening, everyone.
Good evening, ma'am.
Good evening, ma'am.
So, should we start the class or should we wait for some more time?
We should start, ma'am.
Okay, so are you expecting any more students to join?
They may be joined, ma'am, consequently. No problem.
Okay, so we are already 10 minutes, down the time. So we'll start off, I guess.
Yes, ma'am.
Okay, fine. So today we'll be discussing on the maternal pelvis and the fetal skull. Okay, so which is of very important significance. You have to understand the pelvis and the fetal skull is important in a way to understand the anatomy, which indirectly or which is directly related to the events in especially the labor, that is the mechanism of labor, the delivery, and all those things. Okay, so we'll start with the basics first, as we have done in the last class. I'll briefly go ahead with the anatomy, highlighting the important features of the pelvis as well as the fetal skull and few terminologies, and then at the end we will come up with the related MCQs. Good?
Yes, ma'am.
Right. So to begin with, the pelvis, as you see here in the figure, is composed of three bones. That is the sacrum, the coccyx is the lowermost part which is attached to the sacrum, and two inanimate bones here on the either side, right? So each of these inanimate bone is again made up of three separate bones. One is the ilium. Okay, this is the ilium. The lower portion here is the ischium, and then the central portion here in the medial portion is the pubis. So these are the three different parts of the inanimate bones. So these three bones are joined together, and at these particular joints, that is the symphysis pubis, join each other in the midline, and that is a fibrocartilaginous joint. The sacroiliac joint, that is the sacrum and the iliac bone, joined together on both sides, that is the left and the right, and the type of joint is synovial joint, and the sacrococcygeal joint is a synovial hinge joint. Now, what you have to remember here is the pelvis as a whole is not a single unit, in the sense it is not a cylindrical unit all throughout. Okay, upper part is deficient here, as you can see, the upper part is deficient, and actual cavity is only in the lower part. So it has been divided into false pelvis, that is the upper portion, which does not have a boundary on the anterior side. On the anterior side, it is only bound by the abdominal wall, is it not? Only in the lower portion, there where it is completely in a bony cage or bony structure. Okay, so that is particular part is only the true pelvis or the pelvis brim. Now, why you have to understand the false pelvis and true pelvis is that in the time of the labor or the delivery, it is only the of any obstetrical importance is the true pelvis, or the per se the pelvic cavity through which the fetus has to pass. So that's why that is more of obstetrical importance, whereas the false pelvis is not of obstetrical importance, and it only forms a support to the growing uterus during the pregnancy. Now, how these two are separated is by the plane of
Pelvic
inlet,
brim.
what we call as the plane of inlet or the pelvic brim. Okay, you can see this colored structure here which is marked, that is the pelvic brim. So this separates the false pelvis with the true pelvis. Okay, now the sacral the boundaries or the what you call the structures which are present along the pelvic brim from posterior to anterior is the sacral promontory. This is the sacral alley. Then you have the sacroiliac joint, the iliopectineal line. Then you have the iliopubic. This is the iliopectineal eminence. Then you have the upper border of the superior rami of the pubis. Then you have the pubic tubercle, then the pubic crest, and then comes the upper border of the pubic symphysis. So the same thing on the other side, this completely forms the pelvic brim or the upper border of the pelvic inlet. Now, as you can see again in this figure, this is the false pelvis. This is the true pelvis, which is bound, which is separated by the inlet, which is also corresponding to the linea terminalis. Okay, so here you can see the pelvic cavity again. The true pelvis is again divided into three portions. We have the pelvic inlet, then you have the pelvic cavity, and the pelvic outlet. Right. So let us understand these three things now. So another thing is this about the pelvic inlet. The most common kind of the pelvis which is found in the females is a gynecoid pelvis, and that is what we'll be discussing now in detail. So this is the normal kind of pelvis, that is the gynecoid pelvis, which is found in most of the females. So this gynecoid pelvis, when you study the pelvic inlet, it is mostly round in shape, and it is narrow in the anterior posterior dimension, and it is widest on the transverse dimension. That means the inlet is somewhat oval shaped, which is narrow anterior posteriorly, and it is wide transversely, so it is transversely oval. That is the shape of the inlet in the gynecoid pelvis. Now the plane of the pelvic inlet, what you have to imagine now is the plane of the pelvic inlet. There is something called as plane of the pelvic inlet, as is a line passing through the pelvic inlet. Okay, so this pelvic plane, or the plane of the pelvic inlet, is not straight. Okay, imagine if you imagine this as the body, and this is the spine here, curvature spine. What you have to remember is the pelvic inlet is at the angle to this body as well as to the horizontal here. Okay, so this angle at which the plane of the pelvic inlet makes with the horizontal, this angle, particular angle, is called as the angle of inclination. Okay, and this angle of inclination, as you can see here, is about 55 degrees. So the angle which the plane of the pelvic inlet makes with the horizontal is called as the it's called as the angle of inclination. It's about 55 degrees. How do you calculate radiographically this particular angle of inclination? This is of obstetric significance. Is you have to draw a straight line from the junction of this is the lumbar vertebrae, that is L5, the last lumbar vertebrae, the L5, and then the first sacral vertebra. So from the junction of the last lumbar and the first sacral vertebra, you draw a line along the pelvic inlet, and when you compare it with the horizontal, what you can see here is this lumbar vertebrae and this axis of the sacral vertebrae here, and this line joining, they form an angle. So this angle can be calculated radiographically, and this angle, when you minus it with 180 degrees, so 180 degrees minus 135 degrees, that is the angle between the lumbar and the sacral vertebrae. This will give the angle of inclination. Okay, so this is of obstetrical significance. We'll discuss in the later part. Did you all get this? What is angle of inclination?
Yes, ma'am.
Okay, so remember, it's acute always 55 degrees, and it's not at right angles to the horizontal. Okay, now how it is important is that whenever there is an increase in the angle of inclination, which is also known as high inclination, here what happens, increase in the sense, when there is something called as, there is lumbarization of the sacralization of the last lumbar vertebrae, that is the lumbar vertebrae is almost in line with the sacrum. So here what happens is this line, when you draw it along the pelvis axis, will be like wider. Okay, it will be wider like this. So what happens, instead of 55 degrees, the angle of inclination here will increase. It will become more obtuse kind of an angle. So when there is an increase in the angle of inclination, the problems which might occur during the labor is there is delay in the engagement of the fetal head, there is delay in the descent of the fetal head, as well as it favors a more of a occipital posterior position. So all these terminologies we will understand in some time, but you have to remember that whenever there is a lumbarization of the sacralization of the lumbar vertebrae, the angle of inclination increases, and this will cause a problem in delay in the engagement of the fetal head, descent of the fetal head, as well as even in the malpositioning of the fetal head. So these are the three things what you have to remember. Now, what you have to understand, another thing is there is something called as axis of the pelvic inlet. Okay, so or the pelvic cavity. Now, axis of the pelvic inlet is line drawn which is perpendicular to the plane of inlet. So when you, this is the plane of the inlet. So when you draw a perpendicular line to this, that is the axis of the pelvic inlet, which is downwards and backwards direction. Okay. Now, once you extend this through the, if you extend for arbitrarily, if you extend this should meet the umbilicus anteriorly, and posteriorly it should meet the coccyx. So that's how arbitrarily you understand this is the plane of the pelvic inlet. Now, it is important for the proper descent and engagement of the fetal head, and it is also important to remember that the axis of the pelvic inlet should be in line with the axis of the uterus. Imagine if the uterus is here, the axis, that means the long axis of the uterus plus the long axis of the pelvic inlet, if it coincides and if it is in line with each other, then this will favor the fetal head engagement as well as the descent. So that's how you have, is the importance of the axis of the pelvic inlet. Now, other things what you have to remember in the pelvis is all the diameters of the pelvis you have to remember. That is the diameters in the inlet, mid cavity, as well as the outlet. Okay. Now, the diameters of the pelvic inlet, they can be divided mainly into anterior posterior diameters as well as the transverse diameters. Now, in the anterior posterior diameters, there are three important diameters what you have to remember. Okay. One is true conjugate, which is also called as the anatomical conjugate, obstetric conjugate, as well as the diagonal conjugate. There are three anterior posterior diameters what you have to remember. Well, let us understand what they are. Now, the true conjugate or the anatomical conjugate is measured from the midpoint of the sacral promontory here to the upper border of the pubic symphysis. So the black line what you're seeing here, that is the true conjugate, right? So that measures about 11 centimeters. Whereas the obstetric conjugate is one which is extending from the midpoint of the sacral promontory again to the point which is about posterior on the inner surface of the pubic symphysis, on the inner surface of the pubic symphysis. This is the obstetric conjugate, right? That measures about 10 to 10.5 centimeters. Now, diagonal conjugate is one with the blue line, what you're seeing here is the diagonal conjugate, which extends again from the midpoint of the sacral promontory to the point extending up till the lower border of the pubic symphysis. So these are the three important anteroposterior diameters of the pelvic inlet you have to remember. And as I told, the true or the anatomical conjugate is 11 centimeters. Obstetric conjugate is 10 to 10.5 centimeters, and the diagonal conjugate will be about 11.5 to 12 centimeters. Clear?
Yes, ma'am.
Any doubt or confusion with this?
No, ma'am.
Right. So the salient features of few things what you have to understand here is that the true conjugate is of no obstetric significance, in the sense it will not cause any hurdle during the fetal descent or engagement. It is the obstetric conjugate which is important to us, because this is actually representing the true space which is available for the fetal head to negotiate inside the pelvis. So obstetric conjugate is the one which is important to us, and which will tell how much is the space available for the fetus to actually enter into the pelvis. Okay, and also because it is the smallest anterior posterior diameter, and as I told, it is important for the to understand how much is the space available for the fetal descent. Okay, understood?
Yes, ma'am.
Now, another thing what you have to remember is clinically, like how, if at all you want to measure the anterior posterior diameters of the inlet when you want to do the pelvic assessment, it is not possible to assess clinically the true as well as the obstetric conjugate. Okay, so true and the obstetric conjugate can only be assessed by either either by radiologically, or through other things like the ultrasound or the MRI. Right? Clinically, if you want to approximately measure how much is the anterior posterior diameter of the pelvis, what you can measure is only the diagonal conjugate. The diagonal conjugate, how it can be measured is like you can see in the figure here. Clinically, when you are doing a pelvic examination, you introduce two fingers into the vagina, and you sweep your fingers from lower to upper side until you feel the prominence of the sacral promontory. So for example, if you're doing it with right hand, you sweep the fingers from lower down until you reach the sacral promontory. And with the left hand or the index finger, you try to depress your right hand as much as possible. Sorry, and mark the point at where you can feel the lower border of the symphysis pubis. So this area here from your middle finger, which is almost touching the sacral promontory, to the point where you're feeling the lower border of the symphysis pubis, mark it, and then when you measure it outside, will give you, it will approximately give the measurement of the diagonal conjugate. Understood? So as I mentioned, the diagonal conjugate is usually 12.5 centimeters. And if you have to calculate the obstetric conjugate from diagonal conjugate, then remember that the obstetric conjugate is about 1.5 to 2 centimeters lesser than diagonal conjugate. Okay. For example, if they give that X is the diagonal conjugate, okay, X is diagonal conjugate. So the obstetric conjugate will be X minus 2. For example, if they given a question, the diagonal conjugate is 12.5 centimeters, then how much is obstetric conjugate? Then you have to do 12.5 minus 2, that will be equal to 10.5. So the obstetric conjugate will be 10.5. Got it?
Yes, ma'am.
Right. Now coming to the transverse diameters of the pelvic inlet, it's about 13 to 13.5 centimeters, and it is the distance between the farthest 2 points on the iliopectineal line. And it is also the largest diameter of the pelvic inlet, and it lies about 4 centimeters anterior to the promontory and 7 centimeters behind the symphysis pubis. There are also oblique diameters of the pelvic inlet, which measure about 12 centimeters. The right oblique diameter passes from the right sacroiliac joint to the left iliopubic eminence, whereas the left diameter passes from the left sacroiliac joint to the right iliopubic eminence. As you can see in this figure, if you can the right or the left oblique diameters, they'll be dependent on the from which iliac bone they're arising. Okay, so this is the right. I'm unable to draw it here. Okay, so this is the right oblique diameter, and this is the left oblique diameter. Got it? So that's about the diameters. Now coming to the pelvic cavity. As we discussed earlier, the whole of the pelvic cavity is divided into inlet, then the mid cavity proper, and then you have the outlet. Okay. What you can remember here is it is bounded by the pelvic brim above, and there is another plane in the pelvis that is called as the plane of the least pelvic dimensions. So this is the area what we call it as the inlet. Okay, now the plane of the least pelvic dimensions extends from the lower border of the symphysis pubis to the tip of the ischial spines. Okay, to the tip of the ischial spines, this and then up to the tip of the fifth sacral vertebra posteriorly. So the one from the lower border of the pubic symphysis along the tips of the ischial spines up till the fifth sacral vertebra posteriorly. This is the plane of the least pelvic. This is called as the plane of the least pelvic dimensions, and this forms the lower border of the mid pelvis, right? These are the things you have to remember. And below the plane of the least pelvic dimensions is called as the outlet. This area will be the outlet of the pelvic cavity. Okay.
Yes.
So again, this is the same concept what has been trying to explain. But what you have to remember here, important at the mid pelvis is the least pelvic dimensions. The plane of the least pelvic dimensions is very important because it is a landmark or a particular area where all the so many of the events will occur. First of all, it is the plane where internal rotation occurs. Internal rotation of the fetal head occurs at this level. Then it also marks the beginning of the forward curve of the pelvis. As you can see there, the curve of the pelvis is called as the curve of Caras, if you can remember. Okay, so it is initially backwards and downwards, and then it will turn along the curve of the sacrum forwards, and it will turn forwards, is it not? So at the point where it changes, or the point where it changes, that also occurs at the level of the least pelvic dimensions. So one is the internal rotation of occurs here. It marks the beginning of the forward curve of the pelvic axis. Whenever there is a deep transverse arrest, so in an abnormal kind of a labor, there is something called as deep transverse arrest. That means there is no internal rotation occurring. Okay, I hope some of you remember the mechanism of labor. You have got an idea about the mechanism of labor.
Yes, ma'am.
We can discuss it in future classes, but as of now, you remember there is an internal rotation occurring, is it not? Now, if you consider this pelvis, what happens is if the position of the fetus head is posterior like this, or what you call, this is the anterior frontanelle, this is the posterior frontanelle. So there is something called as internal rotation, is it not? So what happens, there should be an internal rotation where the occiput or the posterior frontanelle should come and lie just in front of the sacrum. This is actually the movement of the internal rotation which is occurring during labor. So what happens in case there is a mid pelvic contraction, or where there is inadequate contractions in the uterus, or because of the deflexed head sometimes in the fetus, so this internal rotation does not occur, and the fetus will continuously lie in this transverse position only. That is usually occurring at the level of the ischial spines. So when this rotation does not occur and the fetal head stays at the same position, that is the transverse position, for a longer time, that is more than an hour at the level of the ischial spines, then we call it as a deep transverse arrest. Understood? So this is the plane where the deep transverse arrest occurs, and following that, if at all there is a if when we diagnose that there is a deep transverse arrest, the management changes to cesarean section. We can't prolong the labor more. So this is one important thing what you have to remember and understand. Now, ischial spines is also the plane where we arbitrarily define the station of the presenting part of the fetal head. For this to understand, I would like to show a figure. I think I've just missed it somewhere. So what you have to understand here is like when there is the pelvic walls, right? So there are two ischial spines here. And whenever the fetal head is at the level of the ischial spines, we call it that the fetal descent is at the level of the zero station. Okay. Anything above it is measured or termed as +1, +2, and sorry, it's -1, -2, and -3. Anything above the level of the ischial spines is minus, and anything below it is +1, +2, and +3. So mainly the station is used to define the position of the presenting part of the fetus in terms to the pelvis, like mainly to denote how much is the descent of the presenting part. Understood. So zero station is depicted at the level of the ischial spines. Anything above it in centimeters is -1, -2, -3, and below it is +1, +2, and +3. Understood?
Yes, ma'am.
Okay. And another landmark for the ischial spines is that the external os of the cervix lies at this level, and it also corresponds to the origin of the levator ani muscle. And this is a landmark where we use to give the pudendal block in case of any surgeries involved in the vagina or in the cervical region. So these are the important points you have to remember regarding this landmark in the pelvis, that is the ischial spines. Okay. So as you can see here, the interspinous diameter is 10 centimeters, which is the smallest diameter in the pelvis. Okay. And another important thing what you have to remember. Coming to the outlet, it is lozenge-shaped cavity bounded anteriorly by the pubic symphysis, pubic arch, and then you have the ischial tuberosities, sacrotuberous ligaments, and the sacrospinous ligaments, and the tip of the coccyx. Now, the plane of the anatomical outlet it passes along with the boundaries of the anatomical outlet and consists of two triangular planes with a common base. So you can imagine two triangles here with the common base at the in the bituberous diameter. Okay. Now, anterior-posterior diameter of the outlet is extends from the lower border of the symphysis pubis to the tip of the coccyx. It measures about 13 centimeters. And when the coccyx, as you can see, the coccyx is loosely attached to the sacrum, is it not? So there is a movement occurring at the sacrococcygeal joint. So especially during pregnancy, because of the ligaments becoming lax, the coccyx can further move about 1 to 1.5 centimeters. So when the coccyx is in the normal position, it is about 2.5 centimeters lesser than when it can expand to that extent during labor and delivery. Okay. Now the transverse diameter of the outlet is the intertuberous diameter, that is about 11 centimeters, and it is measured in between the inner border of the two ischial tuberosities. Clear?
Yes, ma'am.
Now, another thing what you have to remember here in the outlet is we divide the anterior posterior diameter of the outlet into two parts at the point where the intertuberous diameter meet. So it is divided into anterior sagittal diameter and the posterior sagittal diameter. So anterior sagittal diameter will be about 6 to 7 centimeters, and posterior will be again about 4 to 5 centimeters here. Now, what is important here is the posterior sagittal the posterior sagittal diameter will represent the how much is the capacity of the outlet to to hold the fetal head during delivery. So this is an important criteria to assess if at all there is a contraction in the outlet of the pelvis. That can be that we will study in the next few slides. Now, another part what you have to learn in the outlet is that the two inferior pubic rami, okay, will form a subpubic angle. Okay, normally in the gynecoid female pelvis, it measures about 85 degrees. Now, the space about 2 to 3 centimeters below the subpubic angle here, what you can see, that is called as the waist space of Morris. Okay, normally the width of the pubic arch is such that a round disc of 9.4 centimeters, that is almost equal to the diameter of a well-flexed head, can pass through this pubic arch at a distance of 1 centimeters from the midpoint of the inferior border of the pubic symphysis. Okay, so whenever there is a wider pubic angle, as in the female gynecoid pelvis, the space will be larger so that the fetal head can be accommodated and it passes. If the angle is narrow, if the subpubic angle is narrow, then you can see for the head to accommodate, it will require much larger space, and this space will be larger. The space of Morris will be larger, so the wastage is more here. So the wider the pubic angle or the subpubic angle, lesser will be the space of waist space of Morris, and the fetal head can pass easily. Okay. Have you got this concept?
Yes, ma'am.
Right. Now, there are mild alterations in the female pelvis, okay, depending on the different characteristics in the inlet, mid cavity, and the outlet. And the most common classification of the pelvis is the Caldwell-Mahon classification, where they have majorly classified the pelvis into 4 types. You have the gynecoid, which is the most common, that is 50%. Anthropoid is 25%, is found in 25% of females. Android in about 20%, and platypoloid in about 5% of the females. So the most common is gynecoid, and the most least common is platypoloid. That's what you have to remember. It's only 5%. And let us now study different features of each part of these pelvises. Now, this table will show the different part, that is the nature. That means the can you all see the table properly? Hello?
Yes, ma'am.
Yeah, are you able to see the table?
Yes, ma'am.
Yeah.
First line is
Yeah, the first line
slightly.
is little cut. I guess it's gynecoid, android, anthropoid, and this is the platypelloid. Okay. Second
Yes,
one
ma'am.
is the android. Second one is the android. So this gynecoid is the most common. Then android is also the male type of pelvis. When it's found mainly in the male this thing. And anthropoid is also called as the ape-like pelvis. And plat is the flat pelvis, which is also the least common variety. Now coming to the shape of the inlet, in the gynecoid, it is transverse oval, whereas android it is heart shaped like this, and in the anthropoid it is anterior posteriorly oval. That means the anterior posterior diameter is longer than the transverse diameter. And here it is a flat bowl like pelvis, where again the transverse diameter is longer than the anterior posterior diameter. So this is the shape of the inlet. Now coming to the relationship of transverse diameter to the inlet, as we have explained, the transverse diameter is the inlet is longer and slightly bigger than the anterior posterior. Here it is also greater, and here the anterior posterior diameter is larger, and here the transverse diameter is larger. Okay, subpubic angle is 90 degree in gynecoid pelvis, less than 90 degree in the android pelvis. In anthropoid and platypelloid, it is 90 or more than 90. Okay. Obstetric outcome in different pelvises. Here, the gynecoid is a normal female pelvis, so there is no difficulty in engagement or there is no malposition. And the most common position of the head is left occipital transverse and the left occipital anterior. Whereas in android pelvis, the engagement is delayed. The deep transverse arrest, as we discussed earlier, is a common feature, or there is a persistent occipital posterior position, which is common. Now, the diameter in case of anthropoid pelvis, the diameter of the engagement is anterior posterior diameter. Therefore, the anterior posterior diameter, since it is larger in these cases, what happens is the fetal head engages in the occipital posterior positions most commonly. Okay, though non-rotation is common, it will be persistent occipital posterior position where the posterior frontannulae will be in direct relation to the sacrum. The delivery will occur in the same position, okay, as in face to pubis delivery, even without rotation. Okay, because the mid cavity and the outlet are quite roomy, therefore it allows for the face to pubis delivery in the anthropoid type of pelvis. Whereas in platypelloid, the head will engage with difficulty in the transverse diameter, and there is something called as asynclitism, which occurs more commonly in platypelloid pelvis. We will learn about this in next few slides. Okay, though there is engagement occurring with difficulty, sometimes the head negotiates the inlet by means of asynclitism, and then the normal labor can occur in case of a platypelloid pelvis. Whereas when coming to the gynecoid pelvis, there is usually a normal delivery because there is no difficulty. Android pelvis is the one where there could be a difficulty, as we discussed with deep transverse arrest. Sometimes we might have to end up with a difficult instrumental delivery, but in modern obstetrics nowadays, even though there is deep transverse arrest, or there is difficulty in engagement or outlet delivery, we do not go for a difficult instrumental delivery. Rather, we would prefer to go with the LSCS, which is much more safer. Okay,
Yes,
understood?
ma'am.
So what all the things you have to remember, you just have to go through this slide again and again, because most of the questions are related to these points in the pelvis. Remember, the normal female pelvis is gynecoid pelvis, male pelvis is android pelvis, most common type of pelvis is gynecoid pelvis, least common type of pelvis is platypelloid pelvis. The only pelvis with anterior posterior diameter more than transverse diameter is anthropoid pelvis. Face to pubis delivery is most common in anthropoid pelvis, as I've discussed earlier. It is because of the persistent occipito-posterior position, and since the outlet and the cavity are roomy, because of the good uterine contractions, the delivery occurs by face to pubis. Okay. Then the direct occipito-posterior position is most common again in anthropoid pelvis. Is the same related to the face to pubis delivery. Persistent occipito-posterior position, as we discussed, is most common in android pelvises, and this will result in DTA, that is deep transverse
Deep transverse
arrest.
arrest.
Yeah. Then, as a next point again, DTA or the deep transverse arrest or the non-rotation, a dystocia is most common in android pelvis. Broad flat pelvis is nothing but platypellar pelvis. Transverse diameter is much more than anterior posterior diameter in a platypellar pelvis. Engagement by exaggerated posterior asynclitism. Okay, that is terminology we'll come to understand later. Synclitism occurs in a platypellar pelvis. Suprasubparietal instead of biparietal diameter engages in the platypellar pelvis. So these are salient features of the pelvis and related to the questions which you are getting in the MCQs. Do you get this? Get all these points? It's just like a revision of what we've studied earlier. Okay.
Yes, ma'am.
Now, when we do call it as a contracted pelvis, until now we studied about the normal pelvis. Let us now study about the abnormal pelvis. Abnormal pelvis, mainly of obstetrical significance, we call it as a contracted pelvis. So we define contracted pelvis anatomically as when the one or more of the planes or the essential diameters of the pelvis, what you have studied now, that is either the anterior posterior transverse of either the inlet or the mid cavity or the outlet is narrow, or it is shortened by about zero 0.5 centimeters or by 0.5 centimeters of the normal distance, then we call it as a contracted pelvis. That is the anatomical definition. Whereas obstetrical definition of contracted pelvis is whenever there is a, even though the size of the pelvis is normal or size of the fetal head is also normal, but there are certain situations where either there is alteration in the size or the shape of the pelvis, or there is a uh, um, problem, or there is a what you call disproportion in the size of the fetal head. So in the position of the fetal head rather. So that is the point where there could be again a difficulty in the normal mechanism of the labor, even though the baby is of average size. So this is the definition or the obstetrical definition of the contracted pelvis. Why there could be a contracted pelvis? The reasons for the contracted pelvis could be nutritional, as it is caused due to severe vitamin C deficiency in the early childhood or in the adulthood. It causes rachitic pelvis or the osteomalacic pelvis. And then it could be because of the diseases or injuries to the pelvis. So in case of pelvis, it could be fracture, tumors, or tubercular arthritis. In case of spine, the spinal deformities also will affect the pelvis, is it not? So whenever there is a deformity in the spine, either kyphosis or scoliosis or spondylolisthesis, this also will affect the pelvis. Similarly, any lesion in the lower limb bones, like poliomyelitis or hip joint disease, also alters the pelvis because of the difference in the weight bearing capacities. Because of these abnormalities, there is the alterations in the shape on as a shape of the pelvis. Okay, so these are the other reasons. Now there could be developmental abnormalities leading to abnormal or contracted pelvis, what we can learn as Naegeli's, Roberts, or there could be higher or low assimilation. pelvis. So these are the reasons for contracted pelvis. Now rachitic pelvis, as you can see the salient features, this is quite rare nowadays, and this occurs affects very early in the childhood. If at all the disease occurs early in the childhood, then there is a severe rachitic pelvis development. What you can see here is the SP, or the sacral promontory, is pushed downwards and forwards. Okay, and the inlet is reniform. Reniform means the kidney shape. Because the sacrum is pushed forward, you can see the inlet here. It is like almost like a kidney here. So it's called as a reniform shape of the inlet. AP diameters are shortened, and the cavity and outlet are though widened. So these are the salient features of the rachitic pelvis. Coming to osteomalacic pelvis, here what happens is, again it is because of the severe deficiency of calcium and vitamin D, but affecting in the later age group, that is after the maturity. If it affects, then you get osteomalacic type of the pelvis. Here what happens is, because there is a beaking of the anterior wall, it is pushed forwards, the anterior wall is pushed forwards, and therefore the inlet is almost like a heart shaped, or it has three extensions, as you can see, 1, 2, and 3. So that's why it is called as a triradiate type of a pelvic inlet will be seen in osteomalacic pelvis. As again, SP, the sacral promontory is pushed downwards and forwards, and the lateral pelvic walls are pushed inwards like this. So that will result in a triradiate kind of a in pelvic inlet. So it's the typical of the osteomalacic pelvis. Okay.
Yes.
Coming to Neglis. So Neglis is a form of a congenital anomaly where, though it is extremely rare, it is due to the arrested development of one ala of the sacrum. So you can see here on one side the ala of the sacrum is absent. So what happens is there is a deformity, and it can also be caused by osteitis of the sacroiliac joints in the later life. So then also what happens is there is a single development of the ala only on the one side. So the pelvis is obliquely contracted, and one side at all levels will be contracted towards inside. So this is a typical Neglis pelvis. Robert's pelvis is where both the ala are absent. Okay, so when both the ala are absent, the innominate bones are completely fused with the body of the sacrum. So what happens is there is an extreme funneling of the pelvic cavity or whole of the pelvis. There's extreme funneling of the pelvis. So this is a typical feature of Roberts. So you remember, when there is only one ala of the sacrum is absent, it is Neglis pelvis. When both the alas are absent, alae are absent, it is called as the Roberts pelvis. Okay. So I think we're done with the explanation regarding the pelvis. Any doubts until now?
No, ma'am.
Okay, so you got the basic idea about all these things?
Yes, ma'am.
Okay. Right. So we'll go ahead with the fetal skull.
Okay, ma'am.
So as you can see, the fetal skull is made up of different kinds of bones, and these bones will meet each other, forming the sutures as well as frontanelles. We have two frontal bones, two parietal bones, two temporal bones, and along with the upper portion of the occipital bone and the wings of the sphenoid. The bones are not united digitally but are separated by membranous spaces, which are called as the sutures. So can you all see here?
Yes, ma'am.
Right. So this is the sagittal suture. You have the coronal suture and the lambdoid suture. So these are the two frontal bones, the parietal bones, and the occiput. So the another thing what you have to remember here in relation to the fetal skull is something called as molding. Anybody, what is molding?
Ma'am, during maturation, two parietal bone, one over another.
Yeah, it's not only parietal bones, it is any bone in the fetal skull will override each other. Okay, they'll approximate one upon the other. So that is somewhat helpful in reducing the size of the fetal head, and therefore helping in negotiating the delivery. Okay, so molding to some degree is important, and it is facilitating the delivery of the fetus, but severe degree of molding will be detrimental to the fetus again. So we will study about that later. Then second thing what you have to remember regarding the fetal skull is the position. So position of the fetal presenting part, by fixing an arbitrary bony point on the fetal skull, will tell us the position of the fetal skull in relation to the maternal pelvis. So this is the inference what we get by studying the different sutures as well as the frontanelle. Then the internal rotation also can be made out once you are thorough with the different parts of the fetal skull. So we can make out whether the position of the fetal head is in transverse, or it is in anterior, or it is in the posterior, and whether there is an internal rotation occurring from transverse to anterior and or posterior. So it will give us an idea about the internal rotation also. Then also about synclitism and asynclitism. Now we'll study about these things later. See, as you can see, we discussed molding is important to some degree. So grade 1, they're divided into 3 grades, 2, 1, 2 and 3. Grade 1 is where the bones touch each other but do not overlap. Whereas grade 2 is they overlap, but when you try to separate with the finger, they separate. Okay, as you can see here. They're touching, but they can be separated. Grade 3 is the severe degree where there is a fixed overlapping, and even when you try to separate with the fingers, there is no separating of the bones away. So this is called as a grade 3, and this occurs only in cases of severe degree of cephalopelvic dysfunction, the CPD, where the head is jammed in the pelvis and it is unable to deliver. So in such severe degree cases only there will be molding, and which is detrimental because it will result in tearing of the fetal the tentora, and also intracranial bleeding in the fetus. So that is severe degree molding is detrimental to the baby. Now, coming to the frontanelle, you have to remember is there are actually 6 frontanelle, but the most important one you have to remember is the anterior frontanelle, which is called as the bregma, and the posterior frontanelle, that is also called as the lambda because of a Y-shaped. Now, anterior frontanelle is formed by joining the 4 sutures in the midplane, that is anteriorly the frontal suture, posteriorly the sagittal suture, and either side by the coronal suture. It is diamond in shape, and it's about 3 centimeters in its diameters. The floor is formed by a membrane and it becomes ossified 18 months after the birth. It becomes pathological if it fails to ossify after 24 months. Okay. Again, the posterior frontanelle is formed by junction of 3 sutures lines, that is lambdoid on either side. It is triangular in shape. It measures about 1.2 by 1.2. Its floor is membranous, and though it is in the frontanelle, the nomenclature is misnomer, they say, and it denotes the position of the head in the relation to the maternal pelvis. So what are the different presenting parts of the fetal skull? You have to remember is depending on the degree of the flexion of the fetal head. Okay, so different parts of the fetus will be presenting at the internal os during the time of the delivery. Okay, so what are the different parts of the fetal skull? You have to remember is vertex, then there is a face, then there is a part called as brow. I have got the fetal skull and the pelvis, so if time permits I can show it on the video so that you can understand different parts of the fetal skull. Okay, so vertex is the quadrangular area which is bounded anteriorly by the bregma and the coronal sutures, posteriorly by the lambda, and this is the part of the fetus which will be presenting in a well flexed head. Okay, so this is called as the vertex. Face is again area bounded by the root of the nose. It is the from the root of the this is the face is here actually, the root of the nose along up till the supraorbital ridges. This is the face. Now the brow is the one which is extending from the forehead, that is the root of the nose, until the supraorbital ridges on one side to the bregma on the other. So this is the brow, this is the vertex, and this is the face. So these are the 3 important parts of the fetal skull. Are you clear in this?
Yes, ma'am.
So the important diameters in the fetal skull, apart from that, we should understand certain terminologies, that is sinciput. Sinciput is the most prominent area which is in front here in front of the anterior frontal. This is in the forehead, that is called as the sinciput. Occiput is the area which is limited to the occipital bone. It's again a posterior prominence on the occipital bone, that is called as the occiput. Then the mentum is the chin of the fetus. On either side of the parietal bone you can see the parietal eminences, and the subocciput is a region which is just below the occiput. Okay, so this is the junction of the fetal neck and the occiput. Sometimes is also known as the nape of the neck. So this is called as the suboccipital area. Submentum is then this is a junction of the neck and the chin of the fetus. So this is submentum. So you have to remember this is the sinciput, occiput, parietal eminences, the mentum, subocciput, and the submental region. So these are the important regions what you have to remember. Okay. Coming to the diameters of the fetal skull, again, this is very important. The different diameters of the fetal skull will engage in different positions or attitudes of the fetal skull. Okay, so you have to remember the suboccipito-bregmatic diameter extending from below the occiput, that is suboccipito-bregmatic. So this is about 9.5 centimeters, and it is the smallest anterior posterior diameter of the fetal skull, and this is the diameter which will be engaging in a well-flexed head. Okay, suboccipito-bregmatic. Then coming to the second one is the occipito-frontal. So it extends from the occiput to frontal, that is about frontal bone, that is about 10 centimeters. Okay, then you have the mentovertical. Another one is the suboccipito frontal, that is 10 centimeters. Then you have the mentovertical, which is the largest diameter of the anteroposterior diameter of the fetal skull, that is 14 centimeters. This is a mentovertical. Submentovertical is 11.5 centimeters. This extends from submental region to the vertex, that is about 11.5 centimeters. And you have the submentobregmatic. Submentobregmatic is 9.5 centimeters again. So this is the submentobregmatic. The second largest AP diameter is submentovertical, that is occipitofrontal, 11.5 centimeters. Are you clear with this?
Yes, ma'am.
Okay. So as I mentioned, the different engaging diameters of the fetal skull will be there in different parts of the fetal skull, which are presenting in different attitudes of the skull. Attitude means whether it is well flexed, incomplete flexion, deflection, or a total extension of the fetal head. Accordingly, the part presenting will be in complete flexion vertex, and in partial flexion it will be brow, and in complete extension of the fetal head it will be face. So which are the corresponding diameters of the fetal skull which will be presenting, we will understand here. It is suboccipitobregmatic, that is 9.5 centimeters in complete flexion, that is vertex. Suboccipitofrontal, that is 10 centimeters in incomplete flexion, and the presenting part will be vertex. Occipitofrontal, 11.5 centimeters in marked deflection, and but still the presenting part will be vertex. Mentovertical, which is largest diameter 14 centimeter, will be the diameter in partial extended head, and the presenting part here will be brow. Now submentovertical is again 11.5 centimeters. It occurs in incomplete extension. Here again the presenting part will be in between the brow and the face. And then the submentobregmatic is about 9.5 centimeters, which is the engaging diameter of the skull in complete extension of the fetal head, and the presenting part will be face. The transverse diameters, important ones in the fetal skull, is the biparietal diameter, which extends from the two parietal eminences, and it measures about 9.5 centimeters. Then you have the super subparietal diameter, which extends just below the parietal eminences on either side, and it is 8.5 centimeters. You have the bitemporal diameter, which is the smallest transverse diameter of the fetal head, which measures about 8 centimeters. And then you have the bimastoid diameter also, which is again extending between the two mastoid processes, which is about 7.5 centimeters. So these are the different transverse diameters of the fetal skull. Now Now, what you have to remember here is there is engaging diameters. So, whenever what the definition of engagement, as you all know, is whenever the presenting part or the largest diameter of the fetal skull passes the pelvic brim or the pelvic inlet. So, that particular movement is called as the engagement of the fetal head. Do you understand that? So
Yes.
whenever there is a fetal engagement occurring, so the two diameters of the fetal skull, the two largest diameters of the fetal skull, the anterior posterior diameter as well as the transverse diameter of the fetal skull will have to pass through the pelvic brim. Understood? So which of the transverse diameter of the fetal skull or which of the anterior posterior diameter of the fetal skull will pass through the pelvic brim will depend on the degree of the flexion of the head. Understood. So that's how we should try to understand whenever there is, in the last table, what we have learned, whenever there is a complete flexion of the head with the vertex as a presenting part, the engaging diameter of the fetal skull will be suboccipitobregmatic. Okay. And in partial extension with the brow presentation, the engaging diameter is actually meant to vertical. And in complete extension with the face presentation, the engaging diameter will be submento-bregmatic. So that's how it is important. You should understand that the engaging diameters will depend on the degree of the flexion of the fetal head. Understood? I'll
Yes.
try to explain this with the help of the fetal skull and the pelvis. Let's see how it goes with the time. Okay. We are almost 1 hour post the the session now. I have few more slides regarding the few terminologies. Should we continue this as a second class? Maybe tomorrow, and then I can deal with the MC.
You can continue, madam, now.
You
No?
want me to continue?
I think so you can continue.
You want me to continue?
Yes, madam, continue. Yes.
Okay, sir. Fine. So continuing
Okay.
with the presentation, then there are few things, terminologies. What you have to understand uh, is one is attitude. So attitude is the overall position or with the relationship of each part of the fetus to one another. So as you all know, the attitude of the fetus is always a attitude of universal flexion. In
Flex.
the sense, all the joints of the fetus are in the flexion mode. So there is a flexion at the neck, the limbs, the limb joints are all flexed. At the hip joint, the knee joint, so all the joints are flexed, and therefore the attitude of the fetus is actually of the universal flexion. So that's a normal attitude, right? So the next what you have to understand is the lie. See, all these are basic things, but I would like to repeat and kind of make you all familiar with this. Okay. This is what do you mean by lie?
It's the relationship different part of the fetus with the different part of the maternal pelvis.
No, it's not like that. Lie means the longitudinal axis of the fetus, the relationship between the longitudinal axis of the fetus to the longitudinal axis of the uterus. Understood? So that is called as the lie. So when the longitudinal axis of the fetus is parallel to the longitudinal axis of the uterus, that is a longitudinal lie. Okay. So the longitudinal lie could be where the head is down, that we call it as cephalic presentation, or it could be a breech down, when we call it as a breech presentation. Understood?
Yes.
Yeah. So when the longitudinal axis of the fetus is uh, lying obliquely, this is the maternal axis, and this is longitudinal axis, and this is the axis of the fetus. So this is the what kind of a lie? It is called as a, here in the figure it is not very clear. So this actually is a oblique lie.
Right.
Yeah. And when the longitudinal axis of the fetus is transverse to the longitudinal axis of the mother or the maternal spine, then it is the transverse lie. So got it? What do you mean by lie? There shouldn't
Yes.
be any confusion between in these terminologies now. Okay. Then presentation is again the part which is occupying the lower pole of the uterus. That is called as presentation. So the presentation in longitudinal lie could be either a cephalic presentation or a breech presentation, where the breech is the occupying the lower pole of the uterus, or the head occupying the lower pole of the uterus. And when there is a transverse lie, okay, when there is a transverse lie, the part which is occupying the lower pole of the uterus is usually the shoulder of the fetus. So that's why in transverse lie, we say that there is a shoulder presentation. Understood? So this is presentation means the part which is occupying the lower pole of the uterus. This is the uterus. The part which is occupying the lower pole of the uterus is called as the presentation. Then again, there is something called as presenting part. So the presenting part is again a part of the presentation, in the sense, in case of cephalic presentation, right? So in cephalic presentation, the different part of the fetal skull can present. It could be vertex, or it could be face, or a brow. So this is called as actually this is the presenting part. So presenting part is defined as the part which is felt first on doing an internal or a PV examination. The whatever the part we're feeling first here, that is the presenting part. So it could be vertex, face, or brow in case of cephalic presentations, or it could be breech as in breech presentation, and shoulder as in shoulder presentation. Understood?
Yes, ma'am.
Then coming to the position is again, it shows the relationship of the presenting part in relation to the different quadrants of the pelvis. So when you divide the pelvis into 4 equal quadrants, and this forming the right side of the mother, and this is the left side of the mother, you can define in relation to the pelvis the position of the different presenting parts. For example, in the as you can see in this figure, we are having the vertex vertex is the presenting part, with the posterior frontanale lying on here, and this is anterior frontanale. So in the posterior frontanale is parallel to the plane of the horizontal axis of the female maternal pelvis. Then it is a transverse position. And if the occiput is on the left side, or the back of the baby on the left side, then it is called as the left occipito transverse. Then you similarly you have the anterior frontanale here and posterior frontanale here. Then it will be left occipito posterior. That is towards the posterior side of the maternal pelvis. And in this position, as you can see here, this is anterior frontanale, the posterior frontanale facing this side of the mother. This is left occipito anterior position. So you have to understand what is different positions of the fetal presenting part in relation to the maternal pelvis. Got it?
Yes, ma'am.
Yeah. Let us understand what you mean by syncretism. We had come across this terminology earlier. So whenever there is a engagement of the fetal head occurring, is it not? So whenever there is an engagement occurring, what is happening here? The center of the sagittal suture, sometimes, most of the times, if it is in syncretism, means that it is in the center of the pelvic cavity. Right, it is in the center. Whereas in asyncretism, what happens, this sagittal suture either moves posteriorly or it moves anteriorly, so that there is a tilt in the fetal head, and it will descend or engage in the abnormal position only. So whenever the sagittal suture is tilted towards the sacrum, then what happens is the anterior parietal bone is the one which is presenting here, or you can feel more of the anterior parietal bone. So this is called as anterior parietal or anterior asyncretism. Understood? So whenever in this slide figure, you can see here the sagittal suture is more towards the anterior, and the posterior parietal bone is the one which is presenting. So here it is a posterior asyncretism. So whenever there is a whenever the sagittal suture is occupying the central plane, it is called synclitic engagement. When there is a posterior tilt and the anterior parietal bone is presenting, it is called as anterior asyncretism, and opposite is called as the posterior asyncretism. Did you get this concept?
Yes, ma'am.
So these are the abnormalities which could occur in case of abnormal pelvis or the contracted pelvis, especially as we discussed earlier in platypellar kind of a pelvis. There is the engagement of the fetal head usually occurs in the asynclitic position. Okay. The terminology of engagement where this is the pelvic brim or the pelvic cavity, the pelvic brim, and the fetal head has to cross this pelvic brim. That particular event is called as the engagement of the fetal head. Okay. Coming to the question answers, should we go ahead with the question answers? They're all simple questions and mostly anatomical. And on all the whatever we've discussed right now, they are based on those points only. Should we go ahead with the question answer session?
Okay, ma'am.
um, should we just go start like a quiz? I'll just read out the questions and you people answer as much as possible. Okay. I hope the concepts regarding the pelvis and the fetal skull are all complete. I mean, you have understood most of them.
Yes, ma'am.
Regarding this mechanism of labor and all that thing, maybe we can study when we are discussing about the normal labor and all that. Okay.
Okay, ma'am.
So we'll start with the question answer session then.
Yes, ma'am.
Right. So the question number 1 coming up here. The smallest diameter of the true pelvis is interspinous diameter, diagonal conjugate, true conjugate, or the intertuberous diameter. You need to be quick here. Anybody? Yes? Nobody? Hello?
Yes, ma'am.
Yeah. So are you not able to get the answer?
Ma'am,
You forgot the diameters of the skull, is it?
yes.
Okay. See, how much is the diagonal conjugate? It's about 12.5 centimeters. Is it not?
Yes.
So true conjugate will be about 1 centimeter lesser than diagonal conjugate. So it may be around 11.5 centimeters.
Yes.
Interspinous diameter. Interspinous diameter comes where it is between the two ischial spines. Interspinous diameter is between the two ischial spines, which comes in the mid cavity. So how much is the interspinous diameter? It's 10 centimeters. Okay.
Yes, ma'am.
What is intertuberous diameter? Intertuberous means in between the two ischial tuberosities, that is forming the outlet. It is at the outlet of the pelvis. So this is also wide enough. It's about 13 centimeters. So which is the smallest here?
Mm,
The answer is A. It is interspinous diameter. Okay. As we discussed earlier, interspinous diameter is 10 centimeters, the smallest diameter amongst these, whatever the options they've given here. Okay. And this plane is very important. The interischial spine or that plane of the pelvis, which is in between the two ischial spines, as we discussed earlier, is a very important landmark for various things. Do you remember that slide?
yes, ma'am.
It's very important to remember that, as well as remember that interspinous diameter is the smallest diameter of the true pelvis. Now this is a table for you all to remember here. The diameters, you just have to mug up these. Okay. You have to remember the correct diameters, because it's one of the important questions. You just have to mug up these. So there are anterior posterior in the inlet, mid cavity, outlet. So anterior posterior in the inlet you have 3: obstetric, true conjugate, diagonal conjugate. Obstetric is 10 to 10.5 is the smallest anterior posterior diameter of the inlet. Then true will be 11 centimeters, that is 1 centimeter more, and diagonal will be 2 centimeters more than the obstetric conjugate. Understood? Then in the mid pelvis, the anterior posterior diameter is 11.5, outlet is 13.5. Transverse diameter of the inlet is 13 to 13.5 centimeters. Remember, the transverse diameter of the inlet is wider than the anterior posterior diameters in the gynecoid pelvis we are talking about. Okay. Interspinous diameter in the mid cavity is 10 centimeters, intertuberous is 11 centimeters, and the oblique diameter is 12 centimeters. Oblique diameter is mainly of the inlet. So 12 centimeters. So just this table is very, very important. You have to remember at any cost all these dimensions of the diameters. Understood?
Yes.
Right. We'll skip this one. Second question, most important diameter of the pelvis during labor. Interspinous diameter of the outlet, oblique diameter of the inlet, anterior posterior diameter of the outlet, intertubercular diameter. There is a small mistake here. It's not outlet actually. It should be
Out the inlet.
interspinous means in between the spines. Where does it come? It comes in the mid cavity. So it should be mid pelvis. Right. What is the answer for this question?
Ma'am.
Just now we discussed, no, which is the smallest diameter in the pelvis.
Ma'am, interspinous.
Yeah, so that will again become the most important one. Understood? The oblique diameter of the inlet is normal. That is not of a concern. Anterior posterior diameter of the outlet is also quite large. So that is not of a concern. Intertubercular diameter is also large. So what we're worried most commonly is the interspinous diameter. Why? Because it is the smallest transverse diameter of the pelvis. And if that is smaller, then all the events of the labor will be complicated, or it goes into deep transverse errors, obstruction, and all that as we have discussed earlier. So that's why the interspinous diameter is the most important diameter of the pelvis during the labor. That's what you have to remember. Okay.
Yes.
Next question. Female pelvis as compared to the male pelvis has all except narrow sciatic notch, shallow and wide symphysis pubis, subpubic angle is acute, light and graceful structure, preauricular sulcus is larger. This you will remember only if you know the salient features of the male and female pelvis, but at least few can be attempted, which can be excluded. Yes? Anyone? Shall we go one after the other? Narrow sciatic notch could be a possibility. Yes or no?
Yes, ma'am.
Okay. Then shallow and wide symphysis pubis.
Yes, yes, ma'am.
It is present in the female pelvis, is it not? So this is
Yes.
correct. Then subpubic angle, is it acute? Is the subpubic angle in the female pelvis acute, or it is more,
Obtuse.
it's obtuse?
Obtuse.
This is not present in the female pelvis, is it not? So the
Yes.
subpubic angle is wider in the female pelvis. It is light and graceful structure.
Yes, ma'am.
Yes. And is the preauricular sulcus is larger? Yes. Okay. So we are left with this point is definitely correct. That means it is not true about the female pelvis. And there is this one more point, that is narrow sciatic notch. The sciatic notch in the female pelvis is wider, is it not? It's wider. So both the answers are correct. Answer A and answer C, both are correct here. In the sense, these two are not there in the female pelvis. Did you get the answer?
Yes, ma'am.
I will just quickly go through the points between the male and the female pelvis here. The male pelvis is general built massive. The general shape is deep funnel. Pelvic brim or inlet is heart shaped. It's more of the features of android pelvis. Okay. The pelvic cavity is conical, funnel shaped. Pelvic outlet is smaller, and the greater sciatic notch is narrow. Whereas in the female pelvis, it is slender, smooth, light. Then bony markings are less prominent. It is flat. It's like a flat ball, circular or elliptical pelvic brim. The cavity is broad and round. The greater sciatic notch is larger and wide. Ischial tuberosities are inverted and less widely separated, whereas they are more everted here. And the subpubic angle, as we saw, it is acute. That is about 70 to 75. It is more wider, about 90 to 100. this preauricular sulcus, as we studied in the last slide. So these are the salient features of male and female pelvis. Fourth question, the shortest diameter of the fetal head or the fetal skull is biparietal diameter, suboccipitofrontal diameter, occipitofrontal diameter, or the bitemporal diameter. Yes, anybody?
Ma'am, bitemporal.
Yeah, bitemporal is the smallest diameter of the fetal head. It measures about 7.5 centimeters. All these are 9.5. This is again about suboccipitofrontal is about 9.5 to 10, and occipitofrontal is larger. It's about 11 centimeters. So the smallest here is bitemporal diameter. Okay. Fifth, which type of pelvis is associated with increased incidence of face to pubis delivery? Gynecoid, anthropoid, android, or platypulloid? Yes, this is a very easy one. Come on, quickly. We already
Anthropoid,
have
ma'am.
discussed about this. Huh?
Anthropoid.
Anthropoid. Anthropoid is right answer. Why? Because in the anthropoid pelvis, as you have seen, the anterior posterior diameter is,
More.
uh, yeah, it's longer
More.
and it has more room, and the fetal head engages in a posterior position more often. Okay, it engages in posterior position. There is non-rotation, and therefore there is a persistent occipito-posterior position, and the delivery is by face to pubis. Okay, this you have to remember. Anterior posterior diameter is maximum in which type of pelvis? Platypelloid, android, anthropoid, gynecoid.
Ma'am, anthropoid.
Yeah, correct. We just now discussed, is it not? So anthropoid, the anterior posterior diameter is larger. Triradiate pelvis is seen in rickets, chondrodystrophy, osteoporosis, or hyperparathyroidism.
It's
Yeah.
It's vitamin D deficiency in adult. Okay.
Yeah, so actually
Osteomalacia.
from Malaysia,
Osteomalacia.
but since the other three options here are ruled out, okay, so they are all ruled out by exclusion. What the answer suggestive here is rickets. Okay.
Okay.
Now, eighth question, one of the following features can be used to define contracted pelvis. Transverse diameter of inlet is 10 centimeters, anterior posterior diameter of inlet is 12 centimeters, platypelloid pelvis or gynecoid pelvis. Go back to the definition of the contracted pelvis, if you remember.
0.5 less than normal.
Yeah, so transverse diameter of the inlet is how much?
It's about 10.5 to 11.
Yeah, it's about 11 centimeters actually. Not 11, it's more. Okay. And then anterior posterior diameter of the inlet is 12 centimeters. What is the
Yeah.
anterior posterior diameter of the inlet? We have three anterior posterior diameters of the inlet, is it not? True
Yes, ma'am.
conjugate, obstetric conjugate, and diagonal conjugate. So
Yes, ma'am.
what we are concerned here is obstetric conjugate, and the obstetric conjugate normally it is about 10 to 10.5 centimeters is the cutoff or the critical.
Yes, ma'am.
So if at all the anterior posterior diameter of the inlet has to be less than 10 centimeters, then only we say it is a contracted pelvis according to the definition. But here they have given that the anterior posterior diameter of the inlet is 12 centimeters. So
It's
this
more.
will not form the criteria for contracted pelvis. Other
Yes,
two
ma'am.
things, platypelloid and gynecoid, they are the normal features of the pelvis, is it not? So there is nothing here to define that it is a contracted pelvis. So what we're left with the answer is A.
Yeah.
That is transverse diameter of the inlet is 10 centimeters. This is the right answer because transverse diameter of the inlet is usually 13 centimeters. So about 0.5 centimeter less means even if it is 12 centimeters or lesser, then we can term it as a contracted pelvis. Understood?
Yes, ma'am.
So here again, this slide I have included to put up the discussion as well. As you can see, there is certain critical diameters of the pelvis when we can say that there is a contracted pelvis. That means obstetric. This slide is very important. Please note all the things in this. Understood? When the obstetric conjugate is about 10 centimeters or less, diagonal conjugate is 11.5 centimeter or less. Transverse diameter is less than 12 centimeters. So these are the critical diameters to tell that the pelvis is contracted at the inlet. Okay. Another thing what you have to remember is the contraction could be at the different levels. It could be at the inlet, it could be at the mid pelvis, or it could be at the outlet. Understood? So most of the times the contraction in the mid pelvis and outlet is together. So if there is a, it cannot be only contraction of the outlet or only contraction of the mid pelvis. Usually they both are contracted together, whereas inlet could be contracted separately. So what are the critical things what you have to, the diameters what you have to remember for the inlet is these three, and in the mid pelvis the interspinous diameter as we discussed should be 10 centimeters or lesser. The another thing is posterior sagittal diameter should be about 13.5 centimeters to tell it is a contracted mid pelvis. And in the outlet, intertuberous diameter less than 8 centimeters is again a criteria for contracted pelvis. So this is important slide, and you all should remember the critical diameters. Now another grading for different kinds of contractions as mild, moderate, and severe depending on the obstetric conjugate is there. Remember 9.6 to 10 centimeters is mild contraction. If it is 8.6 to 9.5, it is called as moderate contraction, and if it is less than 8.5, we call it as a severe contraction. So this grading is all based on the radiological findings of the obstetric conjugate. Okay, and it will help us to decide clinically the course of management. So if there is a moderate to severe contraction, then in the inlet based on the obstetric conjugate, then we don't go for the trial of labor or a normal delivery, we directly go for the LSCS. Okay, so only if there is a mild contraction with the obstetric conjugate between 9.6 to 10 centimeters is the case where we can go still for a trial of labor and try for a normal delivery. Understood?
Yes, ma'am.
Coming to ninth question, shortest diameter is diagonal conjugate, obstetric conjugate, true conjugate, all are equal. Come on, this you have to answer. Out of the three conjugates, which is the shortest one and which is the most important obstetrically, through which the fetal skull actually has to pass?
Obstetric conjugate.
Yeah, obstetric conjugate, is it not?
Yes.
So that's the right answer. Longest diameter of the fetal skull is biparietal,
By
bitemporal, occipitotemporal, submentovertical.
ma'am, longest is biparietal.
Longest is biparietal. Biparietal diameter is how much? What is the measurement?
9.5.
9.5. Okay. Bitemporal?
Like 9 or
Bitemporal, we just now had a question on this, is it not? So it is the shortest diameter of the fetal skull. How much it is? You forgot already. It is 7.5 bitemporal. Occipitotemporal? There is nothing like occipitotemporal actually. This is a misnomer because it has to be from occiput to either frontal or bregma, or it's like that. So submentovertical is how much? Submentovertical is how much?
11.5.
Hmm?
11.5.
Yeah, 11.5 centimeters. So amongst the options given here, which is the longest? It is
submental.
submentovertical. Okay, so this is the right answer for this question. But remember, mentovertical. Okay, if we go through the previous slides, mentovertical is actually the longest. Yeah, here mentovertical. Okay, mentovertical is 13.5 to 14 centimeters. Is actually is the most longest diameter of the fetal skull. Then next comes the submento vertical, that is 11.5 centimeters. Understood?
Yes, ma'am.
Yeah. So we come back to that particular question. Answer is answer D, submento vertical. Okay. Now, critical obstetric conjugate for trial of labor is 8.5 centimeters, 9 centimeters, 9.5 centimeters, 10 centimeters. So when do you call the pelvis as contracted? When the obstetric conjugate is how much?
This one about 10 or
10
9.8.
centimeters. Normally, the obstetric conjugate is about 10.5 centimeters. Is it not? Is it not? So when the obstetric conjugate is 10 or less than 10, then we call it as a contracted pelvis, and that is coming into the category of mild contracted pelvis, and then we still can think of a trial of labor. So here the answer for this critical obstetric conjugate for trial of labor. Remember, the question includes trial of labor. So only when there is a mild form of contracted pelvis with the minimal shortening of the diameter, that is about 10 centimeters, then we can go for a trial of labor. Understood? If there is a marked shortening as in these figures given here, we don't go for a trial of labor, we directly go for a cesarean section. So here is in question critical obstetric conjugate for trial of labor. So the answer should be D, wherein there is
D.
a mild degree of shortening of the obstetric conjugate. Understood?
Yes, ma'am.
Right. 12th conjugate of the diagonal is A centimeters. So the obstetric conjugate will be A plus 1, A plus 2, A minus 1 or A minus 2 centimeters. If A is the diagonal conjugate, how do you calculate the obstetric conjugate?
Hmm.
The obstetric conjugate is smaller or larger than the diagonal conjugate? We'll go
Ma'am,
back to that
smaller,
figure
ma'am.
again.
Smaller.
Obstetric conjugate is smaller, is it not? So
Yes,
how
ma'am.
much smaller is it?
About 2.
Yeah, 1.5 to 2 centimeters smaller than the diagonal conjugate is the obstetric conjugate. So we are here. So this was the figure you remember. So
Yes,
this
ma'am.
figure shows the calculation of the diagonal conjugate clinically. Okay. So whereas obstetric conjugate is actually this one. This is the obstetric conjugate. So differences of about 2 centimeters will give you the obstetric conjugate. So always remember obstetric conjugate is equal to diagonal conjugate minus 2
2.
centimeters. Understood? So that's how you can calculate the obstetric conjugate. So here in that particular question, the answer is,
Minus 2.
yeah, answer is D, that is A minus 2 centimeters. Okay.
Yes, ma'am.
13th, there is something called as dystocia syndrome. So we'll come to the features of that. But remember in this question, dystocia syndrome is seen in which kind of pelvis? Android, platypelloid, anthropoid, or ganocoid? So just guess, dystocia means what? Even you don't know, even if you don't know, if I have not touched upon, dystocia means any abnormal
Ma'am,
labor is called dystocia.
obstructed labor.
Yeah, no, it's not only obstructed labor, anything which is deviating from the normal pattern of the labor, that is called as dystocia. Abnormal
Yes,
labor
ma'am.
is called dystocia. So in which kind of pelvis do you expect abnormal labor amongst these four kinds of pelvis?
Ma'am, it's platypoid.
Platypelloid, most of the times what happens here is there is either a small or average size, and somehow it will negotiate and deliver. Whereas android pelvis is the one which is more notorious. Just keep this in mind. Anywhere android pelvis is more notorious, and we come across more problems in android pelvis. Okay, though in platypelloid pelvis it is difficult, but somehow with the average size baby, there could be negotiating engagement, descent, etc., and there could be possible delivery. Whereas android pelvis is the one which is more notorious, where the delivery is not possible, there is arrest and all that. So remember always, dystocia syndrome is more common in android kind of pelvis. Okay,
Okay, ma'am.
right. Next question. The following are the features of dystocia dystrophy syndrome, except the patient is stockily built with short thighs, they have normal fertility, android pelvis is common, often have difficult labor. Android pelvis is common is
Is
one
common
right
and
now we just
B also
understood.
common.
So that's
B
why
also.
there will be a difficult labor. Okay.
Yes, ma'am.
Then we are left with two options. The patient is stockily built with short thighs, and do they have a normal fertility? Which one do you think?
It's except normal fertility.
Yeah, so this is a wrong statement about this particular syndrome. They usually have infertility, so they do not have a normal fertility. This is the right thing about this syndrome, that is, they are stockily built with short thighs. So these are the features of dystocia dystrophy syndrome, whereas normal fertility is not a feature. So the answer will be B here. Okay. So let's quickly go through what is this syndrome. The patient here is stockily built with bull neck, broad shoulder, short thigh. She's obese with a male distribution of hair. Pelvis is androtype. Occipito-posterior is common because of android pelvis. They usually subfertile, irregular periods. There are increased incidence of preeclampsia and post-maturity during pregnancy. And during labor, inertia is common. And they have a tendency to deep transverse arrest because of the android pelvis, and they usually end up in difficult instrumental delivery or cesarean section. And there is also lactation failure during puerperium. So these are the salient features of dystocia dystrophy syndrome. Just remember these features. Okay. Next, information obtained by lateral plate X-ray pelvimetry are all except sacral curve, true conjugate, bispinous diameter, inclination of the pelvis. Lateral view of the pelvis means where you will be able to see the sacrum and the lumbar spine and all that.
Ma'am,
Will you be
bispinous type.
correct? So you won't be able to get the bispinous diameter in the lateral plate or the lateral view of the X-ray of the pelvis, is it not? So the answer is bispinous diameter. CPD or cephalopelvic disproportion is best assessed by CT scan, ultrasound, radiopelvimetry, or pelvic assessment. What do you mean by CPD? You all have an idea, is it not? Cephalopelvic disproportion. Yeah. So there is
Ultrasound.
disproportion between the fetal size or the maternal pelvis, or because of the malposition or a deflexed head or whatever.
Physical examination is the best.
Yeah, that's
Pelvic
correct. Yeah, pelvic assessment by clinical examination is the best method where we assess the cephalopelvic disproportion. Because CT scan, ultrasound, radiopelvimetry, though they'll be able to assess the size of the pelvis, the shape of the pelvis, and all that. But the relative position between the fetal head as well as the maternal pelvis will be more possibly assessed clinically only. So that's why we consider that the pelvic assessment or the clinical method of assessment is the best method to assess the CPD. Okay.
Yes.
So few points about the CPD as we discussed, that it can be best assessed by clinical methods. There are different methods for assessment of the CPD. I'll not go into the details because we're short of time. We'll see in the next class. Okay. 17th, if both the ala of the sacrum bone are absent, the pelvis is called negligis, Roberts, triradiate, or rachitic.
Mm, um, it's, uh, it's negligence, ma'am.
Negligis is wrong.
Sorry, ma'am. It's Robert, ma'am. Negligence is the one Elijah's.
Yeah, and Roberts should be Roberts is
Two Allah.
when both the ala are absent, then it is called as Roberts.
Yes, ma'am.
Okay, no confusion now between this Neglis and Roberts. See, I can see here. Sorry, yeah, Neglis is only one side deformity. Roberts is both side deformity. Understood?
Yeah.
Don't get confused. Sorry. Yeah. Then this is another question where just you have to mention true or false. Pelvis with anterior posterior diameter more than the transverse diameter is android pelvis. What is the feature in the android pelvis? The anterior posterior diameter is more or less than the transverse diameter.
It's less, ma'am. It's heart shaped.
Yeah, so the anterior posterior diameter will be, sorry. Yeah, are you able to see on the screen the
Yes,
presentation?
yes, ma'am.
Yeah, so I think I cannot use the pen now. There's some,
No problem.
yeah. So the answer here is false. That means the
Also,
anterior posterior diameter is not more than the transverse diameter here, is it not? So the it
yes,
will be
ma'am.
smaller than the transverse diameter. So the answer is a false. Coming to the last question today of today's, an abnormal attitude is illustrated by breech presentation, face presentation, transverse position, occipito posterior or occipito anterior. It's a very recent question which has been asked. It's a little tricky one to remember. What do you mean by attitude? That's why I had put up in the slide there. What do you mean by attitude?
Ma'am, attitude is that means long axis of the maternal axis and axis of the fetus, ma'am.
Wrong.
Relationship.
That is not attitude. That is lie. What you're telling is the long axis of the fetus and the long axis of the maternal vertebrae or the backbone. That is lie. That is to define the lie of the fetus. What is attitude? I told no attitude. What is there in the normal fetus is of universal flexion. Universal flexion means what?
Uh,
Yes,
uh,
universal flexion means what? See, the attitude is in the different parts of the baby in relation to each other. So universal flexion means that they are related to each other. Means all the parts of the fetus are flexed. All the joints of the fetus are flexed, starting from the head to the shoulders, the elbows, the hips, and everything. It is in the flexed position, is it not?
yes, ma'am.
So that is called as universal flexion. Now, if you take one of these points one after the other, breech presentation, is it related to attitude? It's more related to lie and presentation and all that. Then coming to face presentation. Face presentation, is there a question of attitude here?
No,
What
ma'am.
when there is a face presentation occurring in the fetus? When does the face present in the fetus?
Ma'am, abnormal lie.
Abnormal lie? No. See, as last in the previous slides, I've explained no different parts of the fetus. Can you see here?
Yes, ma'am.
This is the vertex presentation. This is actually this is the brow and this is the face presentation, where the face is presenting lower down. The brow means this part is presenting lower down. Vertex means the posterior portion of the fetal head is presenting lower down. See, when the head is flexed well, means almost the chin is touching the body of the fetus here. When it is a well flexed head, what is happening is the vertex is presenting. That means it's a normal flexion attitude of the fetus. That is again, it is adhering to the norms of the universal flexion. The head is well flexed, so that's why the vertex is presenting. Understood?
Yes, ma'am.
What is happening in the brow and face presentation? There is extension of the fetal head, means it is going behind here. Can you see? Here
Yes,
it is
ma'am.
slightly going behind, that means it is little deflexed, and then the brow is presenting. Here it is totally deflexed, and the occipital portion of the fetal head is touching its back almost behind like this. Is it not? So when this
Yes,
happens, what is happening here? The face is getting presented.
yes, ma'am.
Understood? So here there is extension occurring. Extension is against the universal law of flexion. Is it
Yes,
not?
yes,
Huh. So when you go back to the question, you understood the concept of extension? Understood the concept?
yes, ma'am.
So when there is a when there is
Transverse position.
No, come back to this point here. Face presentation. What is happening in the face presentation? There is extension of the head.
Extension.
Yeah, there is extension of the head, is it not? So when there is extension of the head, that means it is related to attitude. Attitude should define whether there is a well flexed, whether there is flexion or no. Is it not?
Yes, flexion or extension.
So here in face presentation means there is extension of the head.
Yes, ma'am. This abnormal attitude.
So this question is related to this
At,
particular point here, face presentation. Understood. Whereas
yes,
in
ma'am.
other things, that is in breech, transverse, occiput posterior, or occiput anterior positions, it is not related to the attitude of the fetus. In occiput posterior or occiput anterior will be in the vertex presentations. Both
It's
these
about
will be
yes,
in
ma'am.
both these are positions in vertex presentations where the head is well flexed, as I told.
Yes, ma'am.
Okay, head is well flexed. It is the chin is touching the chest and the vertex is presenting, and therefore the position could be occiput posterior or occiput anterior. Right. So
Yes, ma'am.
these two options are ruled out because there is well flexed head here. Transverse position and breech transverse is also related to vertex only.
Vertex.
Okay, LOT as we have discussed earlier. So
Yes, ma'am.
transverse, occiput, posterior or anterior is all related to vertex presentations where there is a well flexed head. Breech is nowhere related to attitude. Breech
Yes, ma'am.
presentation is nowhere related to attitude. So what is related here to the attitude
Yes, ma'am.
is face presentation in these question.
Actually,
There
this question
mentions
I did not
abnormal
understand, ma'am.
attitude. Huh?
I did not understand first, ma'am. Question what?
Yeah,
What
that's
question?
why it's very tricky. So you have to read it properly. An abnormal attitude. They have asked the abnormal attitude. An abnormal attitude means which is against the universal law of
Extension.
flexion. Understood.
That's the
So, in which of these options there is abnormal attitude? It is face presentation, where there is a extension of the
extension.
fetal head than the flexion, which is normal.
Yes.
So that's how you have to really kind of think and actually out of the box and eliminate the right answers and then come to the correct option. Understood. So this was
Okay,
one
ma'am.
tricky question which I had presented at the end. Hmm? So
Okay,
this
ma'am.
was there in one of the exams. I don't remember, but it's a recent one only. So did you all get a good orientation regarding the pelvis, fetal skull, and the questions based on that?
Yes, ma'am.
Okay, so I think we come to the end of the today's session. There is a lot in the female pelvis and skull. As I told, we have to learn about the mechanism of labor, the different positions, and even the abnormal labor and different kinds of labor. That is the normal delivery, face to pubis delivery, breech delivery, and all that. Okay, so we will this knowledge of the basic knowledge about the fetal skull and the pelvis will help us to understand all those things in future. Okay,
Yes.
so please go back and read and remember all the points which I have highlighted. Any queries or questions from your end?
No, ma'am.
How do you feel the presentation? Is it better? Are there any suggestions?
It's better, ma'am. Actually, I think, ma'am, uh, it's you presented in that time. It's quite very much better, but in this way, we think we can't finish all the courses, ma'am, within short period of time.
Okay, so you feel this is good enough for you all?
Yes, it's good enough, ma'am. It's quite good enough, but
Okay.
we think we should go something fast and something that is most related to MCQ discussion. Your presentation is like, ma'am, means fully conceptual and fully
Huh.
details. That's why
Yeah.
it really help us. But
Mhm.
we think it's not possible to complete all those things within a
Okay.
short period of time, ma'am.
So, when is your timeline? Like, when do you, when are you going to appear for the exam, or how much
Like
time is there for you
August
to
or
finish
September.
your
Maybe August or September.
August or September itself?
Yes, ma'am.
Okay. So now how many students are there who are taking in August, September?
Ma'am, like 10 to 12 students.
Mm-hmm. Okay. So like you want me to kind of go a little bit faster with covering only the MCQs and the related theory and discuss only those points.
Yes, ma'am. Yes, yes.
Okay, okay. No, but last time when there was a feedback to go ahead with the theory part and then the MCQs, right? So
Ma'am.
that's what we were
In
trying
this,
to.
the way is correct, ma'am. The way is best for us, and it's the one of the best presentation. But uh, uh, if we, you just understand what I am telling, that
Yeah, yeah, I know. Got it. Hmm. So you want me to be a little more faster in the sense covering more MCQs than the
yes,
theory.
ma'am, yes, ma'am, that's right.
Yeah, yeah. Okay, fine. Thank you, Roshan. I'll try to kind of, prepare something like that.
Okay, ma'am.
So should we end the session here, sir?
Okay, ma'am. Thank
Right.
you, ma'am.
Thank you, sir. Thank you
Okay.
so much.
Okay. Stop.